Hey guys, what's going on? Guess who's back? It's me, Dr. Linville, and today we're going to go over the spine, surgical interventions, and post-op considerations for the rehab specialist. That would be you guys. So let's dig right into it. Not a terrible amount of information today. As you'll see, the spine has some continuity to it. You know, obviously there's different sections of the spine with different considerations, but overall the anatomy is relatively similar from cervical through lumbar. So you'll see that a lot of the procedures we can do throughout the entirety of the spine, and we'll get into some of the differences as we move along. So the spine is a very, very intricate in its anatomy, but it's beautiful in its complexity. And you know, if you just do a simple Google search on images of the spine, it goes from all the way from Da Vinci's drawings on the left, when he was digging up corpses and you know, back in the Renaissance time, and trying to draw anatomical representations of the spine, all the way until to today's drawings. And there's something awe-inspiring and beautiful about the complexity of the human spine. Objectives for this course are to determine the most common surgical procedures for the different regions of the spine and the post-op considerations and precautions that accompany each, and then engage in constructive discussion regarding the management of post-operative patients and when and how to progress more active individuals. In class on Tuesday, what we'll be doing is, you know, you'll listen to this in preparation, and then we'll be doing a lot of things in lab. Especially exercise progression, both post-op and non-post-op, but also going over the progression of how to go from a very basic core stabilization or deep neck flexor stabilization exercise to more involved and more serious ones. We really want to incorporate therapeutic exercise progression into this course. Let's review just a little bit of spinal anatomy. You know, there's 5 sections: cervical, thoracic, lumbar, sacral, and coccyx. We'll be focusing on the top 3 there. You know, there's 7 cervical vertebrae, 12 thoracic, and 5 lumbar. And these are obviously the most mobile of the segments, and the ones that, because of that mobility or lack of stability, maybe causes some issues that might need surgery. And I don't want you guys to forget about the importance of the curve. You know, each curve in the lumbar spine serves its own purpose, and there are 2 lordotic curves, which are the cervical and lumbar, and then 2 kyphotic, which is the thoracic and sacral, and there can also be scoliotic curves, and those can be seen both in the thoracic and lumbar, and actually, you know, it can be seen in the cervical spine as well. It's just commonly referred to as torticollis rather than scoliosis. So when you get into your pediatrics class, you'll learn a lot more about torticollis, and I encourage you to look it up now, just as some supplemental research that you could do. As far as scoliosis goes, vast majority of scoliotic curves are right-sided C curves, and I know in your last class period you were able to go over some different treatments and things for scoliosis. I think we'll continue that Tuesday. But you know, as far as I can tell, a lot of my patients have very benign but noticeable scoliosis. It always seems to be right-sided. There's an increased right rib hump, and something we should take into consideration. If we review the anatomy of the actual vertebrae, this is going to be important, especially when dealing with the surgeries, because a lot of the surgeries are done on the bony anatomy. It's usually due because there's arthritis at specific spots, or there's stenosis, which, if we clear up what stenosis actually is, stenosis just means a narrowing of something. So in this case, it would be narrowing of the actual spinal canal or the vertebral foramen, or narrowing of the foramen that sit kind of laterally where the nerve roots come out of, any of those areas can become stenotic. It doesn't just mean bony overgrowth. It could also mean that there's disc protrusion can create stenosis, or inflammation can create stenosis. So stenosis isn't really the disease, it's just the description of the disease. So if we look at the bony anatomy here, there's a couple areas I really want you to focus in on, and that would be the lamina, which you notice here and here, the spinous process, and then also the facet joint. These are three areas that are commonly operated on to try to allow some decompression of either the disc, the nerve roots, or the spinal cord itself in their areas of bony overgrowth or impingement. We'll get into spinal decompression surgeries in a minute, and then I want you to review this anatomy. So common procedures, as I mentioned before, there are some really common procedures in the different sections of the spine due to the similar comparative anatomy. The cervical and lumbar spines are the most operated sections, and that's likely due to their lordotic curves and the stress that that lordotic curve takes over time from this poor posture or disc herniation or degenerative changes. The thoracic spine obviously takes a lot of stress as well, but there's a little added protection because of the bony anatomy of the ribs and some of the strong musculature that accompanies it. You don't see too much like retrograde slippage of thoracic spine vertebrae. So decompression surgery, this is going to be the first types of surgery that we'll go over, and I have this before different sections of the spine because I believe you can do this and have this procedure done in any section of the cervical, thoracic, or lumbar spine. It's most common in the cervical and lumbar. But decompression surgeries are common in both those previously mentioned areas. It refers to relieving the spinal cord from impingement or stenosis. So there's several different types. One is a discectomy, which is removal of part of the intervertebral disc to relieve pressure on the spinal cord or nerve roots. Another is a laminectomy, which removes the back of one or more of the vertebrae, usually to give access to the spinal cord or to relieve pressures on the nerves. So this would be them actually taking out the spinous processes. A laminotomy, this removes part of the lamina of the vertebral arch in order to decompress the corresponding spinal cord and or spinal nerve root. And as you can already see, each of these is due to relieve pressure. This would be taking out the lamina. A facetectomy, this is a traditional open back surgery, and it's designed to remove a portion of the facet joint or the facet joint itself that has bony overgrowth, or someone who's dealing with facet disease or facet arthropathy that has impacted a nerve root in their spinal canal. They do a lot of injections first into the facet joints prior to surgery. That's one of the indications for surgery, is if you have a failed facet joint injection. So those are sometimes performed there. A foraminotomy or ectomy is performed to expand the openings for the nerve roots to exit the spinal cord by removing some of the bone and other tissue. A foraminectomy refers to a procedure that removes a large amount of bone and tissue. And then finally there's a corpectomy. This is a surgery to remove the body of a vertebrae as well as the discs associated with it, and that's likely due to degenerative disc disease or degenerative joint disease. So let's go over the types of decompression surgery here with a little visual. I think that will help you guys out a lot. It does for me, especially when I was a student. You've got all these otomies and ectomies and so on and so forth, but let's get some visualization there to help you guys. So the first one we'll go over is that laminotomy. And the laminotomy is when they remove some of the lamina. And as you can see in this picture here, in the before and after photos, that laminal arch is creating some impingement, or that red irritation is shown, that compressed spinal nerve. And then afterwards you can see that they've removed that spot and relieved the pressure onto the spinal cord itself and the associated nerve root that's exiting the foramen. if you look at it from a posterior view, that's what it would look like. So they just literally cut a bone into cut a hole, into some of the bony anatomy. A laminectomy is very similar. However, it's similar in the fact that it relieves pressure, and they also cut from the lamina, but they do it on bilateral sides, and then they actually remove the spinous process to provide relief to the spinal cord. Now, they don't usually leave this open. They usually do a fusion associated with it just to provide a little more stability, but you can see there how much bony anatomy is removed to relieve pressure. If we keep going here, we'll see a discectomy, and sometimes it's spelled with a C, sometimes it's spelled with a K. You'll notice both in the literature. But a discectomy, before surgery, you see that ruptured disc, and you see how that disc is kind of the fragments of that disc are popping out of the nucleus pulposa, and it's impinging on the nerve root, creating stenosis at that nerve root in the spinal canal. So in surgery, they'll go in and they'll remove that disc, portion of the disc, and now it's a very, very simple, I say that relatively speaking, surgery, and they actually call it a microdiscectomy, and a lot of times they can go in with lasers now with extreme precision so that they don't damage the surrounding anatomy as well. You'll notice in that picture they also performed a laminectomy, but for the intents and purposes of this, I want you to focus on the discectomy. There's also a facetectomy, and if we go through the A, B, and C here, so A is looking at the facet in question, and a surgical burr is then used to begin removing the bone in that area, and the area of herniation is exposed there in picture B, and then in picture C, the decompression is finally complete, and the herniation and the nerve root is relieved, and then hopefully the symptoms of that patient have decreased. A couple more here. A foraminotomy, very similar to the laminotomy. However, this is done with particular care to the foramen, where the nerve roots come out of, to try to relieve pressure at that area. And then there's that corpectomy, and this is a very, very interesting one, where they remove and relieve the disc above and below a spinal segment or vertebrae that they want to relieve pressure from. So they obviously cannot leave that vertebrae, that vertebral space open, so they have to put in a bone graft, and usually they do that, and then they secure it with plates and screws to create fusion at a 3-level segment. So with all that said, those procedures are very common. They can be performed in the cervical spine as well and in the lumbar spine. Now we're going to get into the cervical spine, and in particular fusion surgeries for the cervical spine and the post-op considerations. So the most common one is the anterior cervical discectomy and fusion, also known as the ACDF. The indications for the surgery, there's a lot, and you'll notice this about spinal surgeries, is there's not a lot of different surgeries that can be performed. There's a lot of different symptoms people have, but we basically do two things to the spine. We either decompress it or we fuse it. So we relieve pressure or we provide stability. That's about it. So a lot of these surgeries are very common for a lot of different diagnoses. So indications here are cervical radiculopathy or myelopathy. The most common disc herniations in order occur at C5-6, C6-7, and then C4 and 5. Indications also can include primary or metastatic tumors, cord or nerve root impingement, degenerative spondylosis, clinical symptoms of myelopathy, as mentioned before, spinal or infectious disease, traumatic disc herniation, or ossification of the posterior ligaments there. Procedure involves removing the symptomatic cervical disc with that discectomy. with an added step of placing a bone graft to encourage bony fusion of the upper and lower vertebrae, and then additional stabilization of the cervical spine with instrumentation. So this is done through an anterior approach, and the fusion is done anteriorly onto the vertebral bodies. You can see in the artist diagram on the top right of the slide the bone graft that they've inserted there to provide some stability at that segment, reinforced with plates and screws into the vertebral body. So an ACDF is what we call it. Post-op considerations. This really isn't healed till about 6 to 9 months post-op. All the progressions between 3 and 6 months are done with caution and with good decision making. Full activity status and resuming of full activity can begin at 6 months post-op, but with physician approval, and I would say even more importantly, with PT approval. So where I work, we work with a lot of surgeons one-on-one. I get a lot of time with them, and they mention to me consistently how important my input is on their clinical decision making as far as return to activity and return to sport. And it's something that you guys need to take pride in as well. And over time, you'll gain really good interdisciplinary communication skills with some of these doctors and surgeons that may seem a little intimidating at first, but they really want to know your input. And as long as you're speaking with clinical relevance and with patient care and safety, they really want to hear what you have to say. So they look to us to clear people to go back to their activities. Typical rehab program is approximately 6 months. I'll see these patients probably for about 3 months until they're back to their normal activities of daily living. And if it's someone like an athlete, which is very rare, then we'll see them up to 6 to 9 months. But return to sports with physician approval. Progressive weight training can be resumed. They can do all aerobic activities, and they need to have full cervical active range of motion, and it needs to be pain-free. Discharge criteria includes understanding of healing outlines and all proper protection. The patient has consistent demonstration of neutral spine, posture, and upper extremity mechanics. Patient verbally and physically demonstrates self-correction when they put themselves in a poor position. Patient demonstrates full functional upper extremity range of motion, also pain-free and full strength. And then the big one is free cervical range of motion with progress towards goal of full cervical active range of motion by 6 months. Just want you to notice, go back for a second, the incision on these patients. The top one is right out of surgery. The bottom one is, I would say, is probably about 6 months out, but they do a good job of looking where your natural skin folds are in your neck and try to make an incision there. And it's usually not done directly anterior, it's usually done lateral, and the reason is because of things like your esophagus and Adam's apple and those sorts of things. This can also be done posteriorly as well. You know, the big difference here is they go in through the back, and there's some different things that can be associated with this. If they want to perform other decompression operations like laminotomy, laminectomy, etc., facetectomy, they would go posteriorly to relieve those areas and then provide a fusion in posteriorly. But some of our rehab considerations and things are very similar. As far as right out of surgery, usually for about the first 4 weeks, these patients are told to wear a cervical collar. But in therapy, we can get that off and start doing some light mobilization and those sorts of things. But if they have screws and plates going into the vertebral bodies, relative amount of their time they want to be spent neutral, so that the plates and screws aren't damaged with increased motion. And then the big thing is, as rehab specialists, we got to understand that if they're in a cervical collar, that means they're not turning on their cervical spine musculature, which means they're going to have a really tough time when they get out of that collar. So it's our job to start incorporating some of that stuff early on in PT safely. Let's jump into the thoracic spine. We're going to go over a couple procedures here. Fusion, and it's usually due to scoliosis. We're going to go over vertebroplasties and kyphoplasty. So thoracic spine fusion is just a little bit different. And one of the big reasons is due to the ribs. Special consideration is taken into the ribs here, and because it's the only area that has those bony projections coming off the side. So the technique isn't terribly different. However, as far as the surgeon's concerned, there is some additional anatomy that they have to be concerned about. Indications for thoracic spine fusion would be scoliosis, instability, maybe if there's a fracture, or any of the aforementioned cervical indications such as tumors and things of that nature. Procedure, involves the removal of part or all of the lamina, covers the back of the spinal column. This helps to decrease the irritation or inflammation of that area, aka decompression. And the surgeon may also remove arthritic changes or disc material that's pressing on the nerve, and then they place screws and rods to fix the spine in place. This is obviously a much larger section of the spine than cervical or lumbar, so the incision, as you can see in that top right, is much, much greater as well. And just think about the fascial restrictions and the scar tissue that patient may be dealing with that might restrict, sagittal plane motion or rotational plane motion in the future. So those are things you got to think about as a rehab specialist. The really cool thing about this is look at the change it can make in someone's postural alignment. I say that with two things in mind. It creates some spinal stability, but it also restricts motion because of that stability. So it's a double-edged sword in a way. I mean, if we can straighten out their spine through fusion to relieve pain, and then maybe we can achieve good pain-free motion. But overall, this is a major procedure that if we can avoid having it done, I think that'd be the best option. Thoracic spine and some parts of the lumbar spine as well are interesting because we can do things called vertebroplasty and kyphoplasty, but it's definitely most done in thoracic spine due to vertebral compression fractures. And vertebroplasty is when they place bone cement into the bone or into the vertebral body. It's injected through a small hole in the skin, which we call percutaneous injection, into the fractured vertebrae with the goal of relieving back pain caused by the vertebral compression fracture. Literally, they cement the vertebrae together. A kyphoplasty is very similar. However, this is just a variation of the vertebroplasty. And the main goal of this one is they try to restore the height that was lost due to the compression fracture. So what they do is they take a surgical balloon and they inject that into the area of the fracture, and then they expand or blow up the balloon to increase that vertebral space and that vertebral height that was lost. And then once that balloon is expanded to the size that they want it, they'll inject that balloon with the same cement to try to create a new vertebral body. And basically works pretty well. The post-operative considerations with these patients: you want to restore as much range of motion as possible, but you want to do it progressively. You do not want to push into their pain. If these patients have a fracture, they're either going to have a couple things happen. They're going to be non-operative fractures, so especially don't want to push into pain or bending, lifting, twisting. With those non-op patients, you want to let that bone heal. And then the big thing is these post-op patients too is, the cement dries pretty quickly, but if they're experiencing pain, you got to really respect that. There's no rush in getting these patients back. They're usually older individuals with very poor posture and movement quality as it is, so you can take your time with some of these patients here. But you'll see this one consideration a lot, the no BLT, and that just stands for no bending, lifting, or twisting. And really they can do those things if they're very slow and controlled and cautious individually, but it's when you start adding multiple components of that together at the same time is where people get into trouble. and it's our job to teach these patients how to dissociate these things, and also watch their movement patterns and try to correct any movement insufficiencies that we might come across. Again, some visual here. We have our vertebroplasty on the left. Percutaneous injection into the fracture site. They're inserting cement for stability, but not restoring any of the vertebral height. That green section is green injection dye, or whatever you want to call it. That's the cement. That's what they're trying to show. And then the kyphoplasty, you can see that a balloon is inserted into the fractured vertebrae. It's then inflated inside the damaged vertebrae to restore the vertebral height, and then special material or cement is injected into that area, and then hopefully that hardens and restores the vertebral height, so that allows better range of motion and stability. Let's get into the lumbar spine. We're going to go over lumbar fusion and decompression considerations. The lumbar fusion is due to everything we mentioned before, but also, the big one here is the spondylolisthesis. And as you guys have probably learned, spondylolisthesis is when one spinal segment is translating anteriorly over the one below it. So this is most commonly seen at L5-S1, but it can also be seen at L4, L5, and maybe even in those young female athletes that are very hypermobile. It can be seen maybe even a little higher. So spondylolisthesis is one of those things that can cause stenosis because of the decreased size of the vertebral foramen or the spinal canal, which can impinge on the spinal cord itself. So they would have to go in, if someone's becoming very symptomatic of this, and do a lumbar fusion to try to correct this. The procedure, it is similar in other areas of the spine. Decompression is performed, and then the spine is reinforced with metal rods, plates, and screws to provide stability to that previously unstable spinal segment. As we look ahead here, here's some of the images, and as you can tell, it looks very similar to the fusion performed in the cervical spine. They do also perform some anterior approaches, which is usually done through a laparoscopy, just as they would do with like internal organs. They just go really deep into your abdomen to get to the lumbar spine anteriorly. They can do that as well. Sometimes that's performed during like a retrolisthesis or a posterior slippage, but pretty rare. And then so you see this L4, L5 segment, how it's slipping forward. That would probably be considered a grade 2. But if you imagine the spinal cord running posterior to those vertebral bodies, you can see how there might cause some impingement and stenosis there. So they go in and they stabilize it. They pull it back in proper alignment. The surgical incision looks something like the picture on the right. That guy looks probably about a week or two out of surgery. So post-op considerations: no bending, lifting, or twisting for 12 weeks. Clearance made by both the PT and the surgeon. Driving. These are the next couple of things. Are some real considerations that I get asked on a daily basis or weekly basis when I have these patients. Driving is possible once the patient is off all narcotic medications and once the patient is ambulating free of assistive drugs, and they've got to present with good leg strength and then also no pain radiating to their legs. As far as having sex, they want to try to limit no segmental motion. You want to keep neutral positions and allow your partner to perform more of the activity. It may start when the wound is healed, and it's kind of a weird subject to bring up early on in your career, but this question gets asked a lot of patients, and sexual health is a big, important factor in people feeling like they can provide for their family and their spouse. So it's one of those psychosocial things that go along with surgery, and especially lumbar surgery. So it's important to be open to talk about it and then give them actual real advice. Okay. Smoking, you want to review with the patient to avoid smoking and all other uses of nicotine. This goes for all surgeries really, but especially surgeries where plates and screws are inserted. Smoking is known to decrease your circulation and impede on your circulatory system, and that's the last thing we want when the body's trying to heal, is to have decreased circulation. Lifting, you want to have them lifting 10 pounds maximum from 0 to 8 weeks. And for healing, most healthy fusion cases do not completely fuse until about 6 months. A lot of times people ask me about a brace. Should they wear a brace? A lot of people come in with them, actually, but this is really surgeon's preference. Some wear a TLSO, hard cast brace for about 2 weeks post-op, but a lot of them then come to see me at 6 weeks post-op, and they're wearing just a singed lumbar compression brace just to add some abdominal, increase the intra-abdominal pressure to provide some lumbar stabilization, which is pretty common. The rehab program for these guys can last up to 6 months. Rehab is initiated in the outpatient world at week 6, post-operatively 2 times a week for 6 weeks at week 6, so I see them until about 3 months post-op. If they want to get back to higher level activities, we'll discharge them at 3 months, and then the doctor might send them back at 6 months for progression to higher level activities, such as running or things like that, or hiking, and increased weightlifting, or come up with an exercise program for them based on their surgery. So if we look into lumbar decompression, the indications and the procedures, we've already mentioned those. The postoperative considerations, these are very common procedures that occur in the lumbar spine, and a lot of patients I get don't get fusions that have had lumbar surgery. So I want to give you guys these considerations and things to follow. It's important to know the pre-surgical diagnosis. So it's very important to notice if they have a laminotomy, where they might have the lumbar spine or the spinous processes removed, as opposed to a facetectomy where the facet joint's removed, because that can change some of their movement patterns, and you want to make sure that if you're palpating and you don't feel a spinous process, you know why you don't feel a spinous process there. These are patients you probably don't want to manipulate for a long time post-operatively, and if you do ever consider doing it to someone who's had this decompression several years ago, you want to know exactly what surgical procedure they had, so that you can make the best informed judgment if you're going to perform any manipulations. Early therapy emphasis for these is on spine stabilization, which we'll go over a big exercise progression, which you want to try to incorporate maximum recruitment of the trunk muscles. You want to do attention to position and weight-bearing sensitivities. You want to tailor their exercises accordingly. You also want to spend some time with attention to their incision and possible use of modalities and or soft tissue mobilization techniques to decrease scar tissue complications. And then you want to do frequent neurological checks. And a lot of times these patients, they've had surgery in an area that was already stenotic, and they were having symptoms, and they'll get out of surgery. Some feel better right away, and some still have some localized inflammation at that surgical site, which that inflammation can be creating similar symptoms and pressure that they were feeling pre-surgery. So it might just take several weeks before that inflammation dies down at the surgical site before they start getting real relief. So that's normal as well. You want to look at active range of motion exercises for the spine. It must be done using disc precautions like those no bending, lifting, twisting. Therefore, you want to reinforce avoidance of unsupported forward bending, twisting, motion that reproduces leg pain. Exercise program should follow spine stabilization principles. We'll go over this. It's important to initiate cardio training early in the treatment to do a few things. Improve your cardiovascular endurance, because a lot of people are deconditioned following surgery, but also to improve their circulatory system to promote healing. Office level work is permitted within 2 weeks of surgery, but you have to really educate them on posturing and self-correction, because they can get into these poor movement patterns post-op and cause increased pain and discomfort for themselves. As far as rehab goes, you want to begin mobilizing of thoracic spine and active range of motion exercises for the spine cautiously. You want to direct lumbar mobilization is avoided early, but that can play a vital role at 8 weeks post-op. You want to make sure their gluteals, hips, and hip flexors, calves, hamstrings, all the lower extremity musculature is you're working on flexibility in those areas so that when the time comes for them to start using them a lot, that there's no soft tissue restrictions or extensibility issues there. You want to instruct and progress the level 1 spine stabilization exercises emphasizing neutral spine in positions of greatest comfort, with flexion or extension bias exercise as needed to avoid position sensitivities and to reinforce structural changes made with surgery. So this is a big one. It's a long way of saying incorporate spine stabilization, neutral spine, and then working in their positions of comfort to gain the most out of your rehab. You want to train in body mechanics and functional movement. That goes without saying. One of the big cardiovascular exercises that a lot of these people like to and want to get back to is walking. So they're allowed to walk for up to 2 miles. You can tell them to walk once in the morning, once at night, and really that's all you can do here in the Arizona summer. And anything that might cause impact, even light impact at this time, like Stairmaster or Nordic Track, you want to avoid for the first 6 weeks. And then the Watkins level 1 exercises are initiated immediately as tolerated, and progression towards level 2 is approaching week 8, and then you can go to those level 3, 4, and 5 over the course of that 6-month time period. So the Watkins protocol example, these are just, we'll try to go over this in class today. These are core stabilization exercises in different body positions and what you might want to progress them to in terms of spinal stabilization for the lumbar spine. So if we look at the column on the very left, it goes over the exercise and then phases 1, 2, 3, 4, and 5. 1 is the easiest, 5 would be the hardest. So I want you to maybe pause it here and then look through this, and we're going to try to do this in class as well. As far as discharging these patients, you want to continue programming for them, so give them an updated home exercise program when you think they're ready to move on to gym-based activities. You want to educate them to continue stabilization exercises at least 3 times per week for at least a year from surgical date out. And you want to do daily focus on hip range of motion, hip flexibility, and posturing. These patients, because they do not have, so I know this one at the top says lumbar fusion, but this goes for lumbar fusion and lumbar decompression. The decompression patients, because they don't have plates and screws, at about 6 months they can get back to running and jogging and active lifestyle stuff like that. Now as far as heavy weightlifting goes, it's not recommended. If surgeon can clear them on some of that stuff, but as far as you go, you want to try to teach them more functional exercises, light weightlifting activities, things that wouldn't irritate them moving forward. So one of the big things is if you have a cervical fusion, what's the return to sport like? Well, Ellis in 2007 came up with these rules for the cervical spine following fusions. There is an absolute contraindication of returning to sport after a C1, C2 cervical fusion. So we're talking about axial fusions here. This is kind of a no-brainer. If someone has a C1 or C2 fracture or a Dens fracture, they got some crazy instability. Especially if they got the fracture in their sport, you want to make sure that they don't return to that sport. A healed, stable, 2-level anterior or posterior subaxial cervical fusion with or without instrumentation is a relative contraindication. So we're talking about a 2-level C3 or lower fusion is relatively contraindicated, and that's really up to the patient. And I put Peyton Manning here because this is what he had. He had a 2-level fusion, cervical, and obviously won the Super Bowl last year. But anyway, it's pretty risky stuff. One hit, paralyzed, one hit, dead, whatever. It's his risk, so there you go. There is no contraindication after an anterior single-level cervical fusion, any level excluding the AA articulation with or without instrumentation that has healed. No return after 3-level cervical spine fusion. So really, if you have a 3-level, means your mobility is limited to the point where it's not recommended to return to sport. There's no contraindication in contact sports following a discectomy and inner body fusion for lateral or central herniation in athletes who have solid fusion and are asymptomatic, neurologically intact, and with full pain-free range of motion. Really, at this point, these cervical fusion patients it's probably not your job to clear them to return to sport. That would be more their surgeon's deal, especially a sport that is high contact, like hockey or football or rugby or something like that. But this is something I wanted you to know because there are athletes that do return after cervical fusions to those sports. The only other procedures I want you guys to be aware of that has to do with the axial skeleton are rib, sternum, and clavicle fractures, and also pelvis fractures. These injuries are typically caused by high-impact activities like a motor vehicle accident, and there's no real protocol for these patients. You want to progress them as planned with good communication with the referring surgeon. And the biggest thing is you want to get the op report and you want to get the images if you can, so you can see where certain plates and screws and rods and wires and things were placed, so that if you palpate and feel something that feels abnormal, or you take them through a range of motion and they're particularly restricted, you know why. The scapula is also another area that can be injured, and it's part of the appendicular skeleton. However, these scapular fractures don't typically require surgery. They just let them heal. But that's something else you want to be aware of. And that's usually caused by the same high-impact activities. So I really appreciate you guys' time and patience with this lecture. I hope you learned something. We'll be glad to go over any questions you might have. And I look forward to seeing you guys Tuesday. Thanks.